You talk about aligning the assessment that's done initially for the patient with the care plan, and then making sure that the services are really following what that care plan is. Can you explain that a little more?
Well, with these 432 different reimbursement cohorts, it's driven by the OASIS assessment that clinicians fill out. And what that does is puts them into one of those 432 different cohorts. And then what you send to the physician on the care plan is a frequency and duration and type of visits that you want to do. Now, as an example, if you tell, if your assessment is incorrect on their functional scores, their ability to walk around it, and you basically say they're independent. And then on your care plan that goes to the physician says that you're going to need 3 physical therapy visits every week. Well, Medicare's essentially not going to pay you for those visits because in your OASIS assessment, you said the patient didn't need physical therapy. And yet in your care plan, you want to provide physical therapy. So that mismatch is such that you really don't get reimbursed for those visits. So that's where you really need to do that assessment in the first few days of an admission and make sure the clinical assessment matches up with the resources you say you're going to put into that patient. And the more clinicians and management understand that, the more successful you'll be, because this isn't some random thing. There is science behind it, but you have to follow the science.
And I would imagine a lot of systems you've seen don't line those pieces up. Is that correct?
Oh, absolutely. And we see some where we quantify that difference from the national average, and it's not uncommon to see agencies, large agencies, that are they're 25% off in the number of visits they're putting to it versus their scoring, and that amounts to a lot of money. It's not uncommon to see an agency with $1 million plus opportunities just in lining up the assessment and the care plan.